Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Jamie Dyson. He's a clinical assistant professor at Graceland University and practices in acute care at HCA Lake Monroe. Today we discuss advocacy, pet peeves in acute care,
And how PT is like Disney World. Let's welcome our guest.
Jamie. Thanks for joining us today.
Thanks for having me, Leo and Ashley. I love talking, so whatever you guys want to throw at me, I am ready to go.
Well,
we're
I've
gonna
got a
talk.
question I just want to highlight. You were recently, you had a role. Was it with House of Delegates? What was that? What did you?
Oh yeah, at the last House of Delegates just a few weeks ago, during the election for APTA Board of Directors, I was nominated from the floor to run in a runoff for the remainder of a position abandoned by Zohar Kaplasi when he got elected to treasurer. So we were all running for a 1-year term to finish out the remainder of his term. And so I was nominated from the floor, and actually I did pretty well. I came in second, which is pretty good. As coming from the floor, I didn't have a chance to campaign, but things did really well. So I'm going to try to get slated for next year. So if anyone's bored and they want to fill out an NC1 for me, I would surely appreciate it.
Okay, listeners, you hear that? I mean, it'd be nice to
Yes.
have an acute care therapist on the board of directors representing us. And I have to say, I was there when Jamie was nominated from the floor because I'm a delegate, and you convinced me. Like your speech, your statement was amazing. I was very impressed, which I'm not surprised at all that I was impressed by you. But yes, it was great.
Well, thank you so much, Ashley. And one of my favorite sayings is rehab isn't a spectator sport. We have a lot of folks that they complain about, healthcare, the reimbursement and the access to care and, the the journey that patients have to go through the continuum of care. Um, I myself take a really active role. I'm always up in DC to advocate for better reimbursement. I'm talking to the insurance providers to try to eliminate those barriers to care. And, you don't think about barriers in the acute care setting. Yeah, everyone comes in the door. It's getting them out the door, which can be a bit of a challenge. And anything we can do to eliminate those barriers for our patients is only going to benefit us as a profession. And in the long run, the bottom line of the hospitals that we work in to save them as much money as possible by moving the patients through the continuum of care in an efficient manner.
Jamie,
I
I think we
believe,
were.
and I quote you, Jamie, when you said, if we want to make a change, we need to stop talking about it and do it.
Absolutely. There's too many people talking and not enough people actually doing something about it. And, APTA is 100,000 members strong. If everyone just did a little something, we'd really be able to make some progress. The other issue, and I'm getting on a soapbox a bit, is we only represent about 30% of the profession. Imagine if we had 50%. Imagine if we had 70%. And those that complain the most are usually those that aren't a part of the solution.
Mhm.
And we need to motivate others to join and become a part of the solution. It'll benefit us as a profession as well as the patients we care for. Imagine a smooth transition from ICU to a regular acute care to outpatient home health, inpatient rehab, whatever the case may be. Other countries are doing it, and we can do it as well. It's just going to take an interdisciplinary teamwork to, come up with a solution to this. I was a patient not too long ago. I had Guillain-Barré syndrome
My
7 years
goodness.
ago.
Jamie, I'm so
Yeah,
sorry.
I contracted it from the flu shot, the annual flu shot.
Oh
And,
my.
one morning I was sitting in the ICU writing some notes. And by that evening, I was sitting in the bed right across the hall from where I was writing notes as a patient. The, the transition of the Guillain-Barré happened fairly quickly for me. I was sitting writing notes and I couldn't get up from the chair. And then before I knew it, I was in the
Wow.
ER. And then before I knew it, I was admitted to the hospital and, right next door to a patient a couple of days ago who I was treating. So,
Wow.
and
Oh
family
my
members were
God.
walking by my room saying, "Isn't that the guy that was working with my family member a couple of
Right.
days
Well,
ago?" And now he's in here.
first of all, Thank you for sharing that with us. I mean, but I mean, I am just really curious. Obviously, you've made a great full recovery, but
Mhm.
what was that experience like being a patient in acute care? Like going from that practicing in acute care and treating patients to being the patient. I would love to hear what your experience was like and if you learned any kind of lessons that you now carry into your practice.
Yeah, well, being on the other side of the table, so to speak, is
Yeah.
eye-opening. One of my Vegas memory, well, not the Vegas memory, one of my big memories that I have was being placed in the MRI machine, and they had to do a full brain and spine, because, of course, GBS is a diagnosis by elimination. And for those that don't know, an MRI of the brain and spine takes about 3 hours.
Mhm.
And I was in the tube getting my MRI while I was continuing to progress. And, it had gone from the extremities to pulmonary. And so I'm laying there flat in the MRI machine as my pulmonary was starting to get a little worse and a little worse. I never got to the point where, it was emergent, but, a little bit of panic was setting in there. So that was one of my memories. And then, the transition from the hospital. And, luckily I had really good insurance, so the transition wasn't that difficult. I, of course, wanted to go home. My wife's a neurocritical care nurse, so she's like, "Yeah, we could probably take you home." And, I
You're in good
probably shouldn't have
hands.
gone home. Yeah, I probably shouldn't have gone home, but I did. And the transition to outpatient was actually a bit of a challenge. I actually had to call the manager of the outpatient clinic because I couldn't get an appointment. Here I was discharged from the hospital and with the facilities that I'd worked at for at that point over 25 years, and I couldn't get an outpatient appointment. So I had to pull my backdoor card and call the manager in order to get an appointment. From there, the approval of visits was just a nightmare. The insurance provider would approve visits 6 weeks at a time, but sometimes it would take 2 weeks to get the approval. So I'd finish my 6 weeks. I'd have to stop for a week or two while we're waiting for approval, and then it was retroactive. So the next 6 weeks started 2 weeks ago. So I'd only have 4 weeks at a time. So there's a lot of work to be done in reimbursement and with the insurance providers. And I've told that
Really?
story to Florida Blue, which is the Blue Cross here in Florida, as well as some other insurance providers here in Florida. I've actually spoken to my congressman, Darren Soto, who's really a strong advocate for physical therapy, and he's actually brought that story up um, in Congress
Mhm.
for as we're trying to work on changes in CMS.
Good for
So he
you.
knows my story really well. So again, you could sit back and say, "Man, this was a horrible time for me," but I'm taking it and I'm using it to help move our profession forward.
So Jamie, I wanna jump on that a little bit about moving the profession forward. You talk about getting all hands on deck, and a lot of new grads and maybe PT students, they're a little bit fearful about how much they're gonna be getting paid or reimbursement or just where the profession is going, especially when they're leaving school with a lot of debt. Now, I remember that it was a talk that you were giving about all hands on deck and advocating for better reimbursement for what we do and the skills and the services, the value that we bring to our patients. Now, if I'm a new grad or if I'm a student, what advice do you have for them if they're kind of fearful about what's going to happen to the profession moving forward in terms of managing the debt to income ratio?
Yeah, and that debt to income ratio is off balance right now. Students are graduating with a tremendous amount of debt, and unfortunately, the reimbursement hasn't caught up to the education. So, yeah, we're a doctoring profession, which is great, but unfortunately, to achieve that doctorate, there's quite a bit of cost that's associated with it. And there's some model programs that are beginning to open up, which are looking at some different models of education, hybrid models and accelerated models in the
Mhm,
hopes
mhm,
of decreasing the debt that's associated with becoming a doctor of physical therapy. But at the same time, even if we make some progress in the tuition rates, we got to work on the reimbursement. We are not being reimbursed to the full extent of our education if you compare it to other doctoring professions.
mhm,
So we've got to work together to get the reimbursement comparable to the education that we have. Now, in the acute care setting, we're not reimbursed specifically for physical therapy. It's a mass program, but the patients, once they leave the hospital, yeah, those therapists are being reimbursed based on, a few different things, but it's not at the rate that is comparable to the education. In
Hmm.
order to overcome this, outpatient clinics need to triple and quadruple the amount of patients that they're seeing, which of course doesn't provide the best care, right?
Right.
Or they just plumb refuse to see patients with certain insurances, including Medicare. And in Florida, that's a huge issue. Most of our patients are Medicare. And if there's clinics that aren't seeing Medicare patients because of the reimbursement, that's going to, make more barriers to care. And,
Absolutely.
part of what I'm trying to do. So yes, there's an imbalance between tuition and reimbursement. But as we present this to legislators, we
Hmm.
don't want to sound a little greedy and saying, yeah, we need to make more money. But
Hmm.
if we present it in a means that says we want to decrease barriers to care, and
Hmm.
here's why there are barriers, and the multi patients at the same time not seeing certain insurances, that's going to affect their constituents. So they tend to get a little bit more on board when they hear, okay, here's a big problem that's going to affect a lot of people, and here's some possible solutions that'll break down those barriers to care.
You mean we can't just walk into the legislator's office and say, "Show me the money," and have a
I
Jerry
mean,
Maguire moment?
you could. I don't know how far you get with that.
Right.
I could certainly
No,
try.
but seriously, like, it blows my mind because, I mean, I think yes, I think we do deserve to make more money because of what
Mhm,
we do, and if you think about how much money we save the healthcare system, like, if they could just reimburse physical
Mm.
therapists a bit better, let us take more
mhm,
time with our patients, we could provide really good preventative care, right? That would then save money down the road from
mhm.
some of these other procedures and problems and conditions they develop because they haven't been taking care of themselves like they're supposed to. I'm on board with your soapbox, but I agree.
Yep.
Show me the money.
Yeah. I compare it, I live in Florida and Walt Disney World. Every year they increase the prices to go to Disney World. I think a one-day pass is like $150 now, but
Oh,
there's a demand for it. People are demanding, they wanna be able to go to Disney World, and they're willing to pay whatever it costs to go. Imagine if our patients had that same attitude with, receiving physical therapy. We need this physical therapy. We want this physical therapy. If we get the public on our side, yeah, those reimbursement rates would go up because their customers would demand it. Insurance companies are going to listen when their customers are saying, "We need better access to physical therapy care." We're just not there yet. And, if you look at physicians, yeah, patients want to be able to see physicians. And well, look at what physicians are being reimbursed. Chiropractors are in there as well. They're getting reimbursed at a higher rate because patients are demanding that they have access to chiropractors. And, we kind of need to follow that model and have patients demanding to see physical therapists. And that will only increase the reimbursement because the demand will be there. It doesn't cost McDonald's $3 to make a Big Mac, but they can charge whatever they want because the demand is there.
We need to be the Disney World.
Yeah, or
right.
the Big Mac, whatever.
Those both sound good. I remember hearing somebody, he was an entrepreneur talking about business. And when you're working with clients, he had said, you want to make your clients stark raving fans. They're not just there to kind of receive a service. You want them to say, man, whatever service they provided, this was amazing. Whether it's like a mechanic, whether it's, a teacher, or whatever that is, retail, it's like, wow, they become a stark raving fan. I feel in my experience, that we as therapists, we're not so good about kind of advocating for ourselves. We kind of bow our heads down, we do
We're
our
so
work.
humble.
Yeah,
Mhm.
exactly. But I don't think we do a good enough job of, you know, educating our patients and letting them know what value that we can provide. And then, yeah, maybe we are humble, but to kind of show that, hey, based on these experiences, we want our patients and clients to leave saying, man, this was a really great experience. I'm going to tell all my friends, go see Jamie. He's a fantastic
Mhm.
physical therapist. I worked with Ashley for 3 weeks and man, she was amazing. Please go see them. So I think that's something that we can work on. And that's something that new grads, students, that's something for every single interaction that they have with a patient or client, that's an opportunity to kind of show the value that we bring.
Absolutely, and I always say, we don't brag, we just confess.
There we
And,
go. I like
um,
that.
we healthcare is a customer service based industry. People don't like to think of it as a customer service, but you could have the best skills ever, but if you don't treat your patients right, they're not going to want to come. But whereas if your
Yeah.
skills are mediocre and you have great customer service, your patient's going to want to come see you.
Mhm.
And, you see it, you see it with restaurants. You see, McDonald's isn't that great, but they treat their customers good. So, yeah, people are gonna go get that Big Mac because it's easy, it's quick, and it tastes okay. And but their
Mhm.
customer service is there. Whereas, yeah, I could get a lot better dinner waiting an hour and a half and,
Mhm.
spending 2 hours in a restaurant. I don't have that
Mhm.
time. So, yeah,
Mhm.
I'm not going to go get that better dinner even though it's better, but I'm more comfortable getting something that's a little quicker.
There's
Mhm.
something to be said, though, for customer service not just being about customer service and making patients happy. There's actually research linked to like
Mhm.
if we take the time to listen to our patients and
Yes.
hear their stories, learn about where they come from, their culture, their identity, we're going to provide better tailored
Mhm.
care. We're going to prescribe better interventions that they're actually going to do that meets their lifestyle. And they're going to have better outcomes as a result. So it's not just about customer satisfaction, it's also about outcomes. And
Mhm.
that's what the insurance
Absolutely.
companies and the legislators need to know and need to hear.
Yeah, I mean, the most important person on the healthcare team is the patient themselves,
Yes.
and
Yeah.
everyone else should be working around the goals and the needs of the patient. And, where I'm at, we do interdisciplinary rounds every day. And, part of the things that we talk about is discharge planning. I work in the ICU. I have patients who are still in comas, but we're making recommendations for discharge, from day one.
Mhm.
And
Mhm.
it's something that we just do. And, you got to be a little bit careful when you're doing that as well. You don't want to, say, oh, this patient may be able to go home because they'll grab that like a dog on a chew toy and hang on
Mhm.
to it. And so you have to be a little bit careful. But, I think it's really important that A, PTs are involved with discharge planning, and B, we're part of that is interdisciplinary team. You're either if you're not on the table, you're on the menu. And that's a saying of our FPTA CEO. He says that all the time. And
Mhm.
we don't want to be on the menu. We want to be at the table making the decisions that need to be made on the patients that we serve.
Well,
Awesome.
Jamie, I think your action speaks pretty loudly. Look, just reading your bio, you've gotten so many awards, excellence in clinical teaching, the Lucy Blair Service Award. I mean, you've done some amazing things, but one thing I know you're really passionate about is unwarranted variation in care. So I
Mhm.
would love to hear your perspective on that.
Yeah. So, I mean, this is not only in physical therapy, but in healthcare in general. And I'm sure everyone listening to this can see this even in the practice setting that they're in. The hospital I'm at, there's a group of physicians, and their practice as far as weaning the ventilator is all over the place. So they like their own certain modes of mechanical ventilation. They want like have their own weaning protocols. So the poor patients are kind of stuck in the middle, depending on which physician is on. And it just kind of slow downs progress. If, we could all just get on the same page with each other, that would certainly help. Us as physical therapists, I can't tell you how many articles we have showing that early mobility in the ICU is beneficial. It decreases length of stay, decreases delirium. The list goes on and on. But there's a lot of variance in practice for us doing that.
Mhm.
Unfortunately, right now with nursing, we have a lot of agency and travelers coming in to cover the ICUs. And I'll
Yes.
go in and move a patient. They're like, I've never seen that done before. I'm
Mhm.
like, well, how many hospitals ICUs have you worked in? Oh, 10, 11, 12. And so we have all this evidence that early mobility is effective and safe and decreases cost, decreases vent days, decreases a whole bunch of stuff, but we're still not there yet. And we need to, as a profession, promote that that best care and decrease the variance. I'm not saying there shouldn't be some variance. Everyone's going to have their particular nuances that they use in treating their patients. But the whole group should be moving as a population forward and
Mhm.
not have that variance in care that you see. We even see it within our hospital. If I'm off a day, maybe that patient won't get out of bed because that particular therapist that picked them up isn't there. But imagine, my perfect world is the patient will receive the same care or comparable care, no matter who's working with them that particular day. And that's really where healthcare needs to be. And it's not just PT. Physicians are like that, nursing's like that. All the professions, depending on what pharmacist is on, will be dependent on which antibiotics are used. It's like,
True.
there's just such a variance in this. We have a lot of work to do. Um,
Well, and I think what I'm hearing you say is, we still need tailored, individualized care to our
mhm,
patients, right? But
absolutely.
kind of those overarching themes need to be like threaded throughout. So I'm just thinking like one practical example is like outcome measures. How often do we actually do outcome measures, right? In our day
Mhm,
to day, you hear we don't have time, we do this and that. But I always say, like, you could say, okay, here's a unwarranted variation in care. Some are doing
mhm.
outcome measures, some are not. So we could say, okay, everyone's going to do an outcome measure. That could be the, you know, non-variance, but then what outcome measure they select is up to them. So
Yeah,
everyone should be
absolutely.
weaning patients off the vent. The settings they use might be different. I think I agree
Mhm.
with you.
Yeah, I just taught a course this past weekend on the complex medical patient, and I was talking about vital signs.
Mhm.
Mhm.
And I asked people honestly, how many of you are documenting vital signs on a daily basis?
You're
And
getting on my
maybe,
soapbox now, Jamie.
Yeah. You've got, yep,
uh,
yep, yeah.
maybe two or three
Oh, out of how
people.
many people?
Oh, there was probably about 50 people.
That
Well,
blows
no,
my
no.
mind. Like
So
I,
but then a bunch of them said, well, we document them at evaluation. And so, okay, so you're documenting at evaluation. How do you know that if they've changed, to that second
Mhm.
treatment, to that third treatment, to that fourth treatment? And it still blows my mind. And there was a study, I can't remember the year, looking at who's documenting vital signs. And, the area of practice that was the best was actually home health.
Mm.
And, I asked the home health therapist,
it's
and the
because
home
they
health,
require it.
absolutely, they require it, and there's a place to fill it in. Imagine if there was a place on the daily notes where you had to fill in vital signs. The
Mhm.
number of people that would be doing it will increase tremendously just because they have to fill in the blanks.
And you can't just take them on rest. Don't even get me started. Oh my gosh, you can't just take them at rest. You also
No.
have to take them like after activity because we are the only ones to
That's
see that response.
right. We're
They go
unique.
in the doctor's
Absolutely.
office and they just sit there.
Exactly.
Yeah.
Yeah.
Well, this
I
could
have a
be a
story. I
yeah,
don't know if I've
okay.
told this in this podcast before, but it's home health and vital signs. I used to work in home health for about 6 or 7 years at a time in my life when I needed flexibility in my schedule. And I was one of those people because this was earlier in my career. I was one of those people that did not take vital signs regularly. This is partly why I'm almost like it's part of my soapbox now.
Mhm.
And I learned my lesson, luckily not the hard way, but the moderately hard way. Our home health agency started requiring it. Like you had to take vital signs every visit. And I was a little resistant to it. I won't lie. But I started doing it on a regular basis. And there was a patient I had seen time and time and time again walk into his home. He is feeling perfectly fine, asymptomatic. I get out my little Omron blood pressure cuff. I take his heart rate and his blood pressure, and his heart rate says 30. And I was like, no, that can't be right. Let me take it again. I take it again, 30. And then I'm like, okay, let me just use my good old fashioned manual skills. Let me just actually see if it's 30. I manually palpated him, 30. And how you feeling, Mr. So and so? He's like, I'm fine. Let's go. And I was like, no, we're not going anywhere.
Mhm.
So I literally, because we were in New York City, got him in a cab, took him to his doctor's office because I called his doctor. They sent him straight to the hospital. He was in complete heart block. Can
Mm.
you imagine if I had started exercising that man?
Oh, yeah, absolutely.
Right? Like, after that, I was like, "Holy cow." Like, and ever since I've been very consistent about my vital signs and passionate and telling everyone about it, and I tell all my students that story because 'cause I'm
Yep.
like, "I don't want that to be you."
No, absolutely. And, it's just something, it has to become the culture of care. And, if we add these things to our culture of care, they don't
Mhm.
become burdensome anymore. I don't even think about having to take vital signs as something I have to do. It's just something that I do.
Yeah, it's just
And
part of your
yeah, it's
routine.
just part of it. And,
Same.
I'm known for, I write them down on paper towels because it's the easiest thing for me to do.
Yeah.
So I'll grab a paper towel on the patient's room. I'll write, the initial and then the during and then the after. And, by after a few patients, my breast pocket's full of paper towels. But,
Oh my
I have
gosh.
my,
You need a more efficient, streamlined method.
oh,
I
no.
have a piece of paper.
Okay. Well, paper towels are always available. So,
Oh, that's
Yeah.
so funny.
but
In a jam, sometimes I'll just write them on my scrubs. I've done that before too, because I'm not going
well,
to laundry them. So I'll just write them on the scrubs.
yeah, I don't want to have to get ink out of my scrubs. So,
I'm just
uh,
imagining you, Leo, with numbers all over your scrubs at the end of the
Yeah.
yeah,
day.
it's a fashion statement with all of the numbers all over
Absolutely.
the
Oh
scrubs. So
my gosh.
that's good. Yeah, but you do something enough, it becomes habit, and that's one of those things that needs to become a habit with us across the continuum, not just in acute care. Acute care, it's actually really easy. I mean, ICU, it's very easy for me to write down vital signs. They're
Yeah.
flashing in front of me,
Exactly.
Yeah.
so I really have no excuse not to. But yeah, we need
That's
to
why my
as
favorite
a
line is an arterial line because I can see the
Yeah.
blood pressure every single second of every single
Mhm.
moment of the session. I love it.
Yeah, but
So
then some people complain because oh, they got an art line. One more thing I have to worry about. And
I
I'm
know.
like, no, I love the art line. Leave that
I
in.
yeah.
do too.
So I have a question for both of you. So Jamie, I had met you, I think, way back in 2015 or 2016. You came to University of Chicago. It
Mhm.
was you, Tracy Norris, Kim Lavenhagen, and Jamie Dyson. Oh no,
Oh,
actually Jamie
that's me,
James Thompson.
James
James
Tompkins. Yeah.
Thompson, yeah. And that meeting, you were talking about vital signs. No, not vital signs, lab values.
Mhm.
You were on this like it was continuing education. Jennifer Ryan hosted it, and you
Yep.
all changed my practice, literally. And that's why I befriended you and some of these other people that definitely have contributions to APTA. But you definitely changed my practice for, if somebody's got hemoglobin at certain levels, we're not treating purely the numbers, we're also treating the patient and presentation. So I wanted to
Absolutely.
ask both of you, because we're talking about working at the top of our practice, scope of our practice. What are some pet peeves that you have of therapists that you feel that need to change to be able to elevate our game? So we talked about vital signs.
Mhm.
Actually, I remember during CSM, you were actually, that was one of the talks that I went to. You were talking about outcome measures, the use of outcome measures on acute care. What are other things that we can kind of inform and educate these new grads and or even all grads across the board, practitioners, that we need to start doing in order to elevate the profession? For me, and I know Jamie, this is a big thing for you too, are the words that we use when we have our interprofessional, interdisciplinary communication, right? The way that we present ourselves and have these conversations, as opposed to, hi, I'm the physical therapist for the patient 606. Can I work with them today?
Oh my
Are you,
gosh.
Yeah,
Yes.
that
can
is
can we
man.
walk the patient down the hallway? So I'm
And
going to
then
open
for
up
the
that can of
patient, do you
worms.
want to
Yeah,
do physical therapy today?
right.
So let,
One of
let
my
me throw that out
okay.
to you
I'm
and see what's going on.
I'm ready to go. I'm ready to go.
I know. How much time do
You
we
know,
have?
I am trying to train our therapy staff that it is not up to the nurse whether or not we see patient in the acute care setting. We are a consultant. Okay,
Hmm.
so the physicians, the attending physician, whoever the admitting physician is consulting us for our expertise. Much like, if the patient has a kidney issue, they're going to consult a nephrologist. I don't think I've ever seen a nurse stop a nephrologist from seeing a patient. So, we
I
need to
love
have,
this point.
yeah, we need to have that same mindset. Okay. Yes, I need to communicate with the nurse because they're the gatekeeper of the patient. If I'm working in ICU and I want to get a patient out of bed, if they're going to CAT scan in a half hour, yeah, I don't want to necessarily get that patient out of bed right now. I may want to defer that. But it's not up to the nurse to say, no, I don't want that patient out of bed. If they don't want them out of bed, they better give me a good reason why they don't want them
Hmm.
out of bed. And, I don't want them out of bed because, all right, they've been bleeding. There may be things that we missed in the chart review. And, not, unfortunately, not everything is in the chart. So there could be something going on, but it's still our decision as to whether or not we're going to work with that patient. Just yesterday, I had a patient, she had a craniectomy and she was going to have her cranioplasty to have the piece of skull put back on. And this surgery wasn't scheduled till 2 o'clock. And I went in at 8 o'clock to say, hey, I'm going to see, Mrs. Jones. That was not her name. I'm just using that name before, today I'm going to get her up out of bed. And, the nurse was like, you can't see them. They're going to surgery today. She's like, they're going to surgery at 2 o'clock. It's 8 o'clock.
Yeah.
And yeah, so, I did a little education with the nurse and I ended up, I did get that patient out of bed and they did fine and got them back well before surgery. And, you know,
And it
everyone
depends
lived.
on the type of surgery, right? Like,
Well, yeah, if they have,
right? Like, if they're in complete hurt block and they're
if
waiting
they're
for
in
a
heart,
pacemaker,
no, that's a
we're gonna
different
wait.
story. Yeah, and so the type of surgery is important too. But
Right.
for cranioplasty, that's actually, that's not going to affect anything.
Yeah,
And I mean, it's good for the patient. I don't have to put a helmet on them anymore, and I won't mess their
absolutely.
hair up anymore. But that's, so we have to be able to make these clinical decisions for the best interest of our patients. There are studies out there, they show every 24 hours of bed rest increases rehabilitation 6 to 9 days.
Mm,
And, we need to be an advocate for our patients to get them moving as soon as possible. At
mhm,
the
mhm.
facility I'm at, we're an automatic consult. So any patient that's admitted to the ICU, whether it's trauma or medicine or cardiothoracic, we have an automatic consult to those patients. Do we get some inappropriate consults? Absolutely. But I think it takes less time to figure out this patient's inappropriate than it does, if you lose 2 or 3 days because you're not consulted on a patient who really needs it.
Right.
So, I'd rather get those inappropriate consults personally, and, they don't take long. Oh gosh, yeah, this patient's been bound for 5 years. They're using a Hoyer lip. I'm not going to make a difference here. Or, they're brain dead. I get consults on brain dead patients, and that's an easy one. That doesn't take long at all to figure that out and, discharge the consult. But we really need to advocate for, ourselves so that our patients' outcomes are the best that they can be.
Jamie, I want to point out too, just even in your verbiage again, because words are important, the words that we use, especially when we talk about ourselves as a profession. You didn't say the therapy orders or the therapy, you said the
No,
therapy consult. And so this whole
absolutely.
idea that we as consultants, this is like a paradigm shift for some practitioners. I know it was for me because you think of yourself a little bit differently. I love what you said about the nephrologist, right? Or the cardiologist, right? The
Yeah.
cardiologist is not going to ask permission from other healthcare providers.
Mhm.
They know that their specialty is this. Our specialty is mobility. So we go in there and to say, okay, this is the information that I can bring to the table to help benefit the patient who's
Mhm.
in the center of this whole story. So I love that concept. And I think our profession would definitely benefit if more therapists view themselves as a consultant rather than I'm here to take orders and to just prescribe
Right,
to me what I'm supposed to do, walk the patient 3 times a day. That's all I'm going to do. Right. It's such a
right.
limiting viewpoint of what we can do as a profession. Again, as students graduate with a doctorate of physical therapy and all this knowledge that they have, you're armed with all these tools, right? With all
Mhm.
this ammunition and weapons to utilize to kind of help these patients. Like we as consultants, I think is such a better viewpoint to kind of help us out.
Well, and in the interest of time, I will not share all my pet peeves, but I will say
I've got
there's
plenty of them. That
there's
was just
like I
one.
know there's a couple I want to throw out there, and I'm gonna be quick about it, but not every patient needs a co-treat. When
Yes.
every
So
Oh, yeah, don't get me
co-treat should
started.
be a last
you're
resort.
stirring the pot. Ashley, you're
I'm gonna
stirring the
stir the
pot.
pot, but let's don't expand on that. We'll talk about that another episode, but co-treat should be a
Okay.
last resort.
Woo.
And then the other thing is it drives me crazy when people complain about a doctor coming in and interrupting their session or a doctor doing this or a doctor doing that. And I'm like, then go talk to the doctor and get to
Yes.
know the healthcare team. Like
Yeah.
it drives
Absolutely.
me crazy. Like I talk to the doctors. I get to know them. If you're a consultant, you
Mhm.
need to talk to them so they hear what you have to say. And you have to establish that relationship or they
Yes.
are gonna walk all over you. And if
Yes.
you get to know them as a human being, it's
Absolutely.
different. And I have several more. I was taking notes for future
Yeah.
episodes
Oh
for
my gosh.
Oh,
yeah.
another big one is it's our policy.
Oh,
So I can't tell you how many times I've heard it's our policy. I'm like, "Okay, can you show me the policy?" And usually there's not a policy, and you know what? If it isn't a policy and it's not right, policies are meant to be changed. And,
I
you
remember
know
the first time I was a new resident, and they were like, I had a femoral A-line, and they were like, yeah, we don't do that." And I was like, "Yes, we do.
yes, we do. Yes.
You don't, but we
Yeah,
do."
exactly. Yeah. Just because you don't do that doesn't mean we don't do that. Yeah.
Right.
Mhm.
Yeah.
And yeah, I mean, we could talk all day about pet peeves and funny stories and all of that, but
Well, I'm gonna shift off of PT for a second, Jamie, because I know that you do martial art and you teach martial arts. Please tell me, how did you get into that? And just whatever you want to share about it,
oh,
because I
yeah.
find that so fascinating.
Mhm. Yeah, I started training when I was 8 years old. I
Oh,
started in the '70s. So and I actually be celebrating my 50th year practicing in 2026. And it's just something it's been part of my balance. And we all know that physical therapy can be stressful, but there's nothing like leaving a hard day at work and beating people up for an hour in the evening to calm your stress down a little bit. But it's
Mhm.
always been something that I've done. I've traveled the world basically practicing and teaching all over the place, and I do practice jujitsu, so I was doing jujitsu before it was cool, before
Yeah,
all the
MMA. Mhm.
UFC and all of that, and, even going back to the first UFC, like, I think it was, like, 20 years ago, the first
Yep.
one,
Oh,
a
he's
lot of
crazy. Yep.
fighters I've actually known because, I'd seen them in the circuit, and, when that first one came out, I was just graduated from PT school. I think it was, like, 30 years ago. I'm dating myself here a bit. But I was like, "Okay, that my risk benefit isn't there for me to compete in this. If I get hurt, I can't work." So,
Right.
um, I opted not to do that anymore. But yeah, I've been training folks for decades. And, PT and the martial arts kinda work harmoniously together.
Yes.
You both need a they both need a knowledge of anatomy and physiology and balance. Balance is a big thing. And, I knew about balance before I started PT school. So my experience in the martial arts actually made PT school a little bit easier because I knew the joint manipulations, I knew balance, I knew, a lot of things. So when everyone else is trying to figure out what balance is, I was like, oh, I know what balance is. I've been doing that for years. And yeah, and our part of our role as physical therapists is, prevention of injury. And I see the martial arts as an extension of that. I work in a trauma center, so I can't tell you how many folks we have come in as a result of an assault, whether it be
Yes.
a physical attack, a gunshot wound, a knife stab wound, whatever the case may be. And, if I can prevent just one person from going through that, I've done my job by training folks in the martial arts. So it is a bit of preventative medicine
Yeah.
by training folks to be able to defend themselves.
So, Jamie, real quick though, for that our audience that doesn't understand what jujitsu is, how is jujitsu unique as a martial art as opposed to other types of martial arts?
Okay. Well, it's kind of funny because jujitsu is the gentle art.
Yes.
And the history from it comes from it's a Japanese art. Believe it or not, didn't start in Brazil. It started in Japan, and it was originally developed by Japanese monks, and their religion told them that they could not strike another human. But
Yep. That's key.
there was lots of thievery
Hmm,
in Japan back in
interesting.
those days, so they developed this way of defending themselves that didn't involve any striking. It's all done through manipulation of movement, balance, and joint manipulation. And so they were able to successfully defend themselves. The really cool part is once they defended themselves, they would actually help to heal the person that attacked them.
Which
And
exactly what you're
a
saying,
lot
Jamie.
of martial
Wow.
artists have forgotten that every martial art has some sort of healing property with it as well. Most of that has been lost through commercialism.
Yeah.
So, I mean, that's why, my PT and martial arts is kind of my yin and yang, where people, I can hurt people, but I can also heal people. And healing them's a lot harder than hurting them. It's really easy to hurt somebody, but to be able to heal somebody is true technique and it's true magic, in my opinion, to be able to do that.
Jamie, we are about 40 minutes in. I think it's time for our rapid responses.
Dun, dun,
Okay.
dun.
When I think rapid response, I'm thinking a code that's called in the hospital and some patients in trouble, but
Well, that's why we
I'll
named it this. That's why we
okay.
titled it.
Okay, I gotcha.
So essentially,
All
we're gonna
right.
give you how long, Ashley? Are we doing a
Minute and a
minute?
half we normally do. Yep.
Minute and a half.
Okay.
We're gonna hit you with some questions, and you just answer them as fast as you can.
Okay.
All right,
All
Now I'm
right.
getting stressed
Ready?
out.
And go.
all right. Jamie, what's your most favorite scrub color?
The darker the better, whatever doesn't show poop and blood, that's my color.
Awesome,
Do you prefer dogs or cats?
Dogs, absolutely.
Jamie. What is on your playlist when you're working out?
Playlist, anything that gets the heart pumping. I'm kind of old school rock, so lots of old rock.
Very cool,
Are
awesome.
you a morning person or a night owl?
Morning, absolutely.
Favorite thing to have for breakfast to start the day if you eat?
Oh, I'm a eggs and bacon guy.
Fantastic.
Favorite TV show?
Right now, I watch a lot of news, and I kind of look forward to see what's going on in the world.
What's the last Netflix binge or marathon that you did in terms of watching a show?
Oh, Ozarks.
Oh, Ozarks,
Yeah.
fantastic.
Oh my gosh, mine is Suits right now.
Okay.
Favorite book?
Favorite book? Well, I've been reading a lot of textbooks lately. I actually just finished a chapter for the orthotics textbook, so I'm gonna say that one right now.
I got a question for you right here. What's your favorite jujitsu submission?
Oh, the strangle.
Ooh,
The
Absolutely. They go
strangle.
out quick.
now you're talking a foreign language. I have no idea what.
Okay.
Okay, time is up, but your last one is you have to fill in the blank. You know you work in acute care when.
When your shoes are no longer white.
Absolutely.
Oh, that's great. Jamie, thank you so much for being with us today. This was a
Oh,
delightful conversation.
thanks for having me.
If our viewers wanted to reach out to you, how could they find you?
You can find me via my email. It's Jamie Dyson, JAMIEDYSON 224, which is my birthday if you want to send me a card at gmail.com.
Awesome.
Awesome.
Well, thank you so much for being here.
Thank
Yeah.
you for having me. This was fun. It doesn't feel like we were just talking for 40 minutes. So
Right. Yeah. And then again, I just want to say thank you again, Jamie, for all that you do for our professional, you do for APTA Acute Care. You've definitely been someone that's influenced me and you've passed the baton to me for certain things. And so thank you for pushing me in the right direction. I know that's something that you kind of talked about, the influence that you had on students and new grads. So thank you for all that you do.
yeah, and we got to nudge. We got to nudge our next generation. That's we could talk another 40 minutes on that. So I'll just leave it
When
with
we
that.
have you back, when we have you back.
Let's
Absolutely.
go out and make PT our Disney World.
Absolutely.
I love it.
Thank
I
you
love
so
it.
much for having
All
me.
right. Bye.
Bye bye.
We would like to thank Jamie for joining us today. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Leo Regulus and Ashley Poole. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay. For more information about APTA Acute Care, please visit our website, aptacutecare.org. Be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Rebecca Seagraves, Jessica Seagraves, Ann Croggan, and Aaron Licati about acute care for the pregnant and postpartum population. Thank you for listening, and may your shoes and scrubs stay clean today.
Just imagining you, Leo, with numbers all over your scrubs at the end
Yeah.
of the day.
It's a fashion statement with all of the numbers all over the
Oh
scrubs.
my gosh.